The college has been running Research Paper of the Year awards for 20 years, and this is a fantastic celebration of research and success by researchers throughout the world, but people who have published high-quality research relating to general practice or primary care. Through the award, the college aims to promote and raise the profile of research in general practice. I'd like to remind you that anybody can make a nomination for a Research Paper of the Year award. You just have to get in touch with CERC at the college and send them details of a paper that's impressed you, inspired you, or helped move your practice forward. And any time of the year is fine. But today we're celebrating the papers that were published in 2015. We received over 80 entries for this award, and the research outline was very diverse in terms of methodology and scope, incredibly varied. And so there are awards made in 6 clinical categories. And for those of you who had the insight and wisdom to come along to the winners' enclosure on Thursday afternoon, you'll have heard a summary of 5 of those categories, so the sub-award winners. But there always has to be one overall winner. And it is my great pleasure to introduce Professor Carolyn Chew-Graham to speak to us about her research, which is the award-winning. Carolyn's research looks at CKD and sharing a diagnosis of it. And it's a really interesting piece of work, and she's going to try and share the clinical relevance of it with us. So Carolyn, thank you, a friend and colleague. And I have to say, I had no voting involved, so there's no bias here, but thank you. I'm so pleased you're here. Thank you. Thank you. I hope so.
Oh, that's a relief. The slides are here. Okay, so thank you very much for staying till this last session, though I appreciate you've not stayed to see me. So I'm going to talk about the Research Paper of the Year, and I'm here representing a much bigger team. Some people's names are on the screen in front of you. So Gavin and Tom remain in Manchester, but Anne Rogers and Anne Kennedy moved to Southampton as we were completing this work, and I'm now at Keele University. And I do need to say thank you very much to Greater Manchester Clark for funding the study. And our publication was actually in social science and medicine, so it's qualitative research methods, but it was embedded in a randomised controlled trial. So just a bit of background to our study. You're all aware CKD, it's asymptomatic. It's thought to be a precondition. I, for one, was quite puzzled when it first appeared a few years ago in QOF, didn't know what it was, had to do some reading up about it. I'd always thought that kidney function declined with age, blood tests are less reliable in older people. What was this CKD? It's associated with multimorbidity, and we've heard at the conference around the new NICE guideline for multimorbidity, which I would ask you to have a look at, and our work certainly chimes with that guideline. CKD is another diagnostic burden. It's another label for people to have to live with. And Tom Blakeman and I did some work in about 2010, interviewing GPs and practice nurses about CKD, what they understood by it. And if Roger Jones is in the audience, he was good enough to publish that paper, which used qualitative methods, and highlighted the difficulties and the tensions that practice nurses and GPs had in dealing with the diagnosis and transmitting that information to patients. So then we moved on to the BRIGHT trial. And the intervention in our trial was a supported self-management intervention, telephone support from the research team to people who were randomised into the intervention arm, people with CKD3. And they were given a booklet with some self-management resources, some information, and signposting to community resources. And the key result of this intervention was that actually people in the intervention arm, their blood pressure came down. Their health quality of life actually improved for the 6 months of the trial, but didn't remain. But their self-management strategies didn't change, which was a slight disappointment. But as with all trials, we were able to do a nested qualitative study. So Gavin interviewed 26 BRIGHT trial recruits, and the focus of our interviews initially was we wanted to explore how people self-managed CKD. But I think, as with all good qualitative studies, we were able to look at the data as we were collecting it and move our focus to people's perceptions of diagnosis, because that's where the interesting data was coming from. So I'm just going to briefly skim through some of the results. Some of our patients denied that they'd got CKD. So 4 people in the trial said, I only found out about having CKD when I came into the study. And this participant said, well, I was so shocked, and my daughter, she made an appointment with a doctor. Why wasn't I informed? And he said, well, I naturally thought another doctor had told you. You see different doctors. I suppose the previous doctors told you. So that illustrated to us not only the fact that people could enter a trial with a diagnosis they didn't know they had, but also that people were not getting the information around CKD, which is what we uncovered when we talked to GPs and practice nurses. So things hadn't changed 4 years on. Other participants we interviewed weren't quite sure of what the take-home message was, or they felt they'd been told it was nothing to worry about. It's on the borderline. I don't know, really. Certainly patients prioritise their physical, their symptomatic problems. So dismissing CKD as it's an old age kidney problem, I've got pain, I've got my diabetes to look after, I've got my husband I'm caring for, who's got dementia. And this participant, who didn't want to be interviewed but notes were taken, said that he'd received very full details about CKD. He was very impressed with what the GP had told him, but actually he felt he was being told to scare him because the patient wanted to stop his medication and CKD was being held over him so that he would continue with his hypertension medication. And we felt that in our participants there were passive patients and more active patients. So people who had a more passive response to information very much vocalised a doctor knows best, I've got full confidence in the health service. Whereas at the other end of the spectrum, there was patient 24 who said, well, I went the following week, I had my blood tests, that showed that my kidneys weren't working to full capacity. The doctor had put me on the kidney disease register, and he was a minority who knew they were on the register, so that I would be kept an eye on. So this person had got full disclosure about their condition, what it meant for them, and were quite happy about being on a register and felt supported and monitored. So in conclusion, we uncovered, and I think this is probably not surprising, that there was limited or partial disclosure of CKD. And this resonates with our professional accounts that I mentioned earlier. We think that this non or limited disclosure limits the treatment burden for patients, so patients don't have another label to deal with. But we also think this might be a sort of paternalism that hasn't been negotiated with the patient, and perhaps it stems from our desire not to cause more suffering to patients, not to cause an extra burden. We feel that a diagnosis that a patient's given has to make sense for that individual, and it has to take account of their social context and their other morbidities and their other drugs. We feel that we've uncovered a real tension between diagnosis as an incentivised activity, as something that's done through QOF and that we have to tick the box for, but then how we work with our patients to try and support them in understanding another label that we've applied, and then to get them to understand that perhaps they need to change the way they manage their health conditions to limit future risk. So we think that there's a need for a meaningful dialogue on the relevance of kidney health within our consultations, and that if the QOF requirement is to remain, then it has to make sense to both patients but also to us clinicians, and we have to know how to deal with it. We think our results speak to the concept of minimally disruptive medicine, so how not to burden the patient and overburden the patient. And again, that resonates with the new NICE guideline on multimorbidity. But I think importantly, our results pose challenge for the enactment of public health policy. So there's evidence for this. It's a good idea to monitor and label people with CKD and get them to change their behaviour. But actually, how does that play out within the consultation and within the practice? I've put any questions, but you're not allowed to ask questions. I've got to go and talk to Helen, so thank you very much.
So I've just got a couple of questions to put to you, Caroline. Thank you for that. Thank you for making, I have to say, a fairly incomprehensible sounding title of the paper. Actually quite straightforward. That was great.
Thank you.
So I guess in my practice, what difference is this going to make to me in my general practice? Does it make a difference tomorrow when I go into practice? Monday, in fact.
I think for some GPs, they'll say, well, I knew this already, I've felt this discomfort and I know how to deal with it. I think for others, they'll think, thank goodness I'm not alone, that I've been puzzling with how to deal with CKD, what to say to patients, and I thought I was the only one. I hope it will make GPs think about how their practice works with CKD. And I think we tend, as GPs, to delegate this work to our practice nurses. And it certainly made me, as we were going through the analysis, talk to our practice nurses about, well, what do you say to patients? Yeah. Are we all saying the right things or the same thing? And it became apparent to me that our practice nurses were using the don't worry about it, it's just because you've got diabetes or it's because you're getting older, you don't need to do anything about it. So people will not change their behaviour. And they will go away thinking, so why do you do the test? Why are you monitoring it if I don't need to worry about it?
Okay, that's a really good point about the whole team using the same language. We've got CKD targets in QOF. Are they the right targets? Should we have CKD in QOF?
I think we should have them. They are evidence-based, but it's, as I referred to, the tension between having this evidence base and then having to operationalise it in the practice. So again, it comes down to what the practice does with that target and giving a message to patients that is cohesive and understandable across the practice.
Okay, finally, a last question, purely because of time. So why don't GPs explain it to patients?
Again, referring to the earlier BJGP paper, they talked about not wanting to burden patients with another label, another diagnosis. They, in 2011, when we did the data collection, were actually quite puzzled about what CKD was. It may be that in 2016 we're a little bit further along the line, but the majority of accounts were around, I don't want to give the patient another label.
Lovely. Thanks ever so much, Carolyn. Don't go away. I would now like to invite our President, Terry Kemple, back on stage, but also Dr. Imran Rafi, who is the chair of CIRG, the Clinical Innovation and Research Group of the College, to present your award to you.